Bismillahirrahmanirrahim. Assalamu alaikum. Dear colleagues and pages, topic of today's lecture is treatment options of H. pylori infection in 2023. In today's lecture, first we shall discuss the different treatment options which are in clinical practice for eradication of H. pylori infection. Then we shall discuss the rational use of these therapies. And at the end, we shall discuss what are the future options for H. pylori infection. So, Bismillah ar-Rahman ar-Rahim. As I said before, the topic for today's lecture is treatment of H. pylori infection in 2023. The learning objectives of today's lectures are to know about the practice essentials of H. pylori infection treatment, to review the concepts of H. pylori eradication therapies. What are these? What are the types? How to use different drugs? Then we shall discuss the rational use of these available therapies. By and large, the drugs used in H. pylori treatment, they are of three types. First class is proton pump inhibitors or potassium channel acid blockers. The second group is that of antibiotics. And the third drug is bismuth. In different therapies, we shall see that either the PPI or PCAB is used in combination of 2 to 3 antibiotics, and at times the bismuth is also added to the H. pylori treatment combo options. And by and large, the duration of H. pylori treatment may be given from 5 to 7 days, or in most of the cases, from 10 to 14 days. What are the treatment options which are given for 5 to 7 days? Let's see those treatment options. One option that's called the triple therapy, where the 3 drugs, they are given for 1 week. One is the PPI, and it is given in the BT dose of the standard. For example, if this is the omeprazole, so it's given 20 milligram twice a day. If this is the lansoprazole, it is given 30 milligram twice a day. If this is the esomeprazole, then it is given 40 milligram twice a day. If this is the dexlansoprazole, it is given 60 milligram twice a day. So the orange, the golden strip will be always for the PPIs or PCABs in this presentation. Then the green shaded lines, these will be for the antibiotics, and the triple therapy for when therapy, the clarithromycin in 500 milligram twice a day, and in combination with the amoxicillin 1000 milligram twice a day. So these 3 drugs are given for 1 week, and the eradication rate with these 1 week triple therapy is 70 to 75%. So this is the one treatment options in those where the treatment is given for 1 week by and large. The second option is, in the first, it was the amoxicillin Now the amoxicillin is replaced by the metronidazole, 400 milligram 3 times a day. Rest the clarithromycin dose is the same and PPI dose is the same. And with this 1 week therapy, the eradication therapy remains the same 70 to 75% of cases. The third option is when the levofloxacin is used in case of the clarithromycin in the dose of 500 milligram once a day, and the amoxicillin and the PPI they are given in the same as it was given in the previous two options. And the eradication therapy here is now slightly better from 75 to 80%. Then comes the 1 week quadruple therapy. Here, the PPI in the standard dose in combination with the levofloxacin 500 milligram once a day and the amoxicillin 1000 milligram twice a day with tinidazole 500 milligram twice a day. And the eradication rate here with this is 80 to 85%. So this is the 1 week quadruple therapy for H. pylori eradication. So if we review these again, the 1 week therapy is four main types. The one is when the well-known triple combination of the clarithromycin, amoxicillin, and PPI is given, and the eradication here is 7 to 75%. In another, the amoxicillin is replaced by the metronidazole for the 1 week. In addition to the clarithromycin and PPI, and eradication rate is here 70 to 75%. When the clarithromycin is replaced by the levofloxacin, the eradication rate is slightly better from 75 to 80%. The previous two, it was 70 to 75%. Then comes the quadruple therapy, where the three antibiotics, the levofloxacin, amoxicillin, and tinidazole, are given in combination with the PPI, and now the eradication rate is slightly better, and it is 80 to 85%. So these are the four main treatment options which are given for 1 week. Now coming to the mostly used 10 to 14 days therapy, we will call it as the 2 weeks. Here, the most famous one is the triple therapy, where PPI in double dose, the clarithromycin in the BD dose, and amoxicillin in the BD dose. Both the two antibiotics and the PPIs, they are given in the BID dose, and during the start food, they are given for the 10 to 14 days. For simplicity, we will divide this therapy into 2 weeks, the first week and the second week. So from day 1 of the regime, they are given to the day 14. So both the 2 weeks, the PPI is given for 2 weeks, erythromycin is given for 2 weeks, and moxicillin is given for 2 weeks. PPI is continued for the rest of the 2 to 4 weeks, depending upon the condition and the response. But the H. pylori triple therapy is given for 2 weeks. Eradication rate here is 80 to 85%. This is very well known and being used in the first line therapy. But in addition to these, we have got so many other therapies as well. Like here, the amoxicillin is replaced by the metronidazole 400 milligram 3 times a day, and the PPIs as well as the two antibiotics, the green ones, they are showing the antibiotics. The gold bar is showing the PPIs. So both these, they are given for 2 weeks, first week and the second week, so for 14 days. And eradication therapy is 80 to 85%. Again, here the clarithromycin is replaced by the levofloxacin 500 milligram once a day, and again the PPI, the levofloxacin, and the amoxicillin, they are given for 2 weeks, and the eradication rate here is by and large 85 to 90%. Again, in this regime, the PPIs, they are replaced by the vonoprazan 20 milligram BID, and again given for 2 weeks is a part of the H.Pylori eradication therapy, and later on it is continued as a acid blocker therapy along with the clarithromycin and amoxicillin, and the eradication rate here is 85 to 90%. The quadruple therapy, as that was given in 1 week, here for the 2 weeks, the PPIs, the standard dose is given in a BD dosages along with clarithromycin, amoxicillin, and metronidazole, and both these three antibiotics and the PPIs, they are given for the 2 weeks as the H. pylori eradication therapy, and later on the PPI is continued for another 4 to 6 weeks. Eradication rate with this regime is 90 to 95%. Then the bismuth quadruple therapy, where PPIs along with the two antibiotics, levofloxacin, amoxicillin, is now given in combo of the bismuth subsalicylate 265 milligram 4 times a day, and all these four drugs, they are given for 2 weeks, first week and the second weeks, and eradication rate with this regime is also 90 to 95%. In this bismuth regime, it's given the levofloxacin, tetracycline, and the bismuth subsalicylate in PPIs. So this is the bismuth quadruple regime containing the levofloxacin and tetracycline. The previous one was containing the levofloxacin and amoxicillin. Here the amoxicillin is replaced by the tetracycline for 4 times a day, 500 milligram. Sorry for this double write-up of this tetracycline. So it is given for the 2 weeks, and the eradication rate here is 90 to 95%. Then in this it was the levofloxacin, and now the levofloxacin is replaced by the metronidazole. So the metronidazole, tetracycline, and bismuth subsalicylate in combo with PPI of 2 weeks therapy. So this is the quadruple therapy of 2 weeks duration. Now coming to the hybrid dual quadruple therapy, hybrid where the two types of drugs are being given, and here I would like to have your attention to the bars are the strips are shown to give the concepts. What is done here? It's a 2 weeks therapy, the hybrid, the 2 weeks therapy. The PPIs, they are given in the first week as well as during the second week along with the amoxicillin. So both the PPI and amoxicillin, they are given from day one and continue till the second week, or they are given for the 14 days. While the clarithromycin and metronidazole, they are given in the second week. So in this hybrid dual quadruple therapy, in the first week there are 2 drugs, while in the second week there are 4 drugs. 2 drugs from the first week, that is the PPI and the amoxicillin, and now the 2 new drugs, that is the clarithromycin and metronidazole. So the first week there are 2 drugs given, and in the second week the 4 drugs are given. And eradication therapy with this is 90 to 95%. This is called hybrid therapy, dual quadruple. In the first week, dual drugs, and in the last week, at the second week's quadruple. Then there's a reverse. What is reverse? Reverse hybrid, quadruple, and then dual. Means in the first week, the 4 drugs are given: PPI, amoxicillin, clarithromycin, and metronidazole. And in the second week, only PPI is continued and amoxicillin is continued. So the hybrid therapy, it's the standard or the classical one, where the first week there are 2 drugs, one PPI and one amoxicillin. And in the second week, the PPI and amoxicillin, the clarithromycin and metronidazole, they are added. While in the reverse hybrid therapy, the metronidazole, clarithromycin, they are given in the first week along with the amoxicillin and PPI, and in the second week only the PPI and amoxicillin, they are continued. So eradication therapy with this regime is also 90 to 95%, as it was with the hybrid dual quadruple therapy, 90 to 95%, or it was with the quadruple bismuth therapy containing levofloxacin, tetracycline, or the levofloxacin, amoxicillin, and the here, with the traditional triple therapy, either vonoprazole or with the PPI, the eradication therapy was 85 to 90%, while in the quadruple therapy, whether 3 antibiotics and 1 PPI, the bismuth containing 2 antibiotics, 1 PPI, the eradication therapy is 90 to 95%, as it is in the uh, hybrid therapy, dual, quadruple, or quadruple and dual. Then there is uh, sequential therapy, and the sequential therapy is that in the first week, PPI and amoxicillin, while in the second week, the antibiotic is replaced by two another antibiotics. So in this therapy, PPI is the eradication therapy. It's is given for the 2 weeks, and then of course it is continued as the acid suppressant therapy. While in the first week, it is given amoxicillin 1000 milligram BD, and in the second week, the amoxicillin is replaced by the clarithromycin and metronidazole. This is called sequential therapy. The difference between hybrid and sequential therapy is that the in hybrid therapy, either these two antibiotics, they are given either in the last second week or in the first week, but the amoxicillin is continued over 2 weeks. In this sequential therapy, amoxicillin is given during the first week, and in the second week, the clarithromycin and metronidazole are given. Eradication therapy in this case is also 90 to 95%. So these were the different treatment options: the triple therapy for 2 weeks, then the quadruple therapy for 2 weeks. Quadruple therapy was either 3 antibiotics and 1 PPI, or bismuth containing quadruple therapy with 2 antibiotics. Then hybrid therapy, where it was in the dual and quadruple, or it was a quadruple and dual, the reverse one. And then sequential therapy, when in the first week it was amoxicillin and then it was stopped and another 2 antibiotics are given. So understanding these different treatment regimens, now let's go for the types of H.Pylori treatment. Out of these 9, 12 therapies, it is the first line therapy when the patient is treatment naive, no antibiotics and no treatment for H.Pylori eradication has been given. So any of these therapy may be given as the first line therapy, and then when that fails, then the second line therapy is considered, and when the second line therapy fails as well, then is the third line or salvage or rescue therapy. So the approach is that we start with the first line therapy, then if that fails, we go for the second line therapy. If that fails, then we go for the third line therapy, which is also called salvage therapy or rescue therapy. Let's consider these in more detail. First, we take the first line therapy. The choice of the first line treatment regimen of H. pylori infection, which I discussed with you, it depends on various factors. And these factors include local prevalence of antibiotic resistance and patient factors such as age, comorbidities, and medication allergies. So which out of these 12, 13, 14 options should be used at the first line? It depends upon the local prevalence of antibiotic resistance, where there's clarithromycin resistance is there or not there, metronidazole resistance is there or not there. So one is that. Second is the patient factors like age, what is the age of the patient, what are the other comorbidities, and what are the medication allergies if they are. And in region with high clarithromycin resistance rates, Levofloxacin-containing triple therapy or bismuth quadruple therapy are recommended as first-line therapy. So this is very important, as I said before. Depending upon if there is clarithromycin resistance more than 15%, then it should be replaced by the levofloxacin-containing triple therapy or bismuth quadruple therapy as the first line. Now, if the first line therapy fails and we embark on the second line therapy, what are the principles of second line therapy? The second line therapy should avoid repeating first line regimens that were already used and should incorporate at least one different antibiotic. So this is very, very important. I told you the different antibiotics combination with the PPIs, including the bismuth as well. So if you are at the second stage where the first line therapy has failed, the first treatment has failed, so what you will do, you will avoid the same regimen and you try to incorporate at least one different antibiotic. Bismuth-based therapy or levofloxacin-containing therapies can be used same regimen as above if not used previously. So this is the principle that what drugs you should use for the second line therapy. In a meta-analysis of 115 heterogeneous studies, per protocol analysis showed that quadruple therapies have better cure rate than triple therapy. With quadruple therapy, it was 83% as the second line, and with the triple therapy, it was 76%. So better you go for the quadruple therapy. And 14 days quadruple treatment, then 7 days was higher. So if one is that as a second line therapy, you go for the quadruple therapy instead of the triple therapy. And second, when you are going for the quadruple therapy, it should be given for 14 weeks or for 2 weeks, for 2 weeks or 14 days as compared to the 1 week or 7 days. So the increased number of drugs, that is the 4 drugs, and for longer duration is the key of success in second line therapy. If in any patient the first line therapy failed, you embark on the second line therapy that also failed, what to do now? What is the third line salvage or rescue therapy? So the principles in the third line or the salvage or rescue therapy is that before initiating third line, that is the salvage or rescue therapy, send ulcer biopsy specimen for culture and antimicrobial susceptibility testing. This is desirable and ideal and should be a sort of principles that in now you do the endoscopy, you take the sample tissue and you subject that for culture as well as antimicrobial susceptibility testing because now the two therapies have failed. It is essential to avoid antimicrobials that have previously been used. This is very, very important. And you go for the details, what therapies have been given as a first line and second line, and then you avoid all those antibiotics because probably the bug is resistant to those. The preferred treatment for patients who have received a clarithromycin-containing first-line regimen are bismuth quadruple therapy or levofloxacin salvage combination therapy. So again, you think about the antibiotics, what were used as the first line, second line, and the type of therapy, whether this was triple therapy, quadruple therapy, and whether this was for the 1 week or 2 weeks, and if this was quadruple therapy, whether this was bismuth containing quadruple therapy or non-bismuth quadruple therapy, and you then proceed accordingly. In general, clarithromycin triple therapy is not recommended for third line salvage or rescue treatment. So this is by and large that when you reach this stage, you don't go for the clarithromycin triple therapy. What are the adjuvant therapies? What about those? Probiotics are live microorganisms, we know that, and these can provide health benefits when consumed adequately. Probiotics, mainly the Lactobacillus, Saccharomyces boulardii, and Bacillus clausii, they have been shown to reduce the side effects of H. pylori eradication therapy and improve the eradication rates. It has been demonstrated that probiotics can effectively enhance the eradication rate of H. pylori and reduce the incidence of antibiotic associated adverse effects such as diarrhea and abdominal pain. This is the one of the side effects of the therapies, one of the ways when there's poor compliance and patients don't take that therapy for the desirable duration or for the advised duration, that is the 2 weeks. So the adjuvant therapies like the probiotics, they does improve the uh, tolerance of the H. pylori eradication therapies. In addition, several H. pylori vaccines, they are being developed and have been shown promising results in preclinical studies. However, further research is needed to determine the safety and efficacy of these non-antibiotic therapies in clinical trials. Uh, in the clinical practice, the failure of the first therapy, the second line therapy, and even the third line therapy is very much. I mean, they are. We do come across these patients, so there is quite a lot unmet needs, and there are so many ways that the therapies, the eradication rate should be improved, and in those cases where the treatment failure is seen, so in such cases, people are embarking on the probiotics as well as the different vaccines. H. pylori vaccines are being developed and they are being tested. So we hope in the days to come, we will get the answers for the treatment failure patients, the resistant bugs, that what to do that. Till then, it is really a problem. But remember that H. pylori being positive probably is not the way to go for the to start on the or embark on the treatment. Probably this is the whole clinical scenario picture where you have diagnosed the H. pylori and you are going to eradicate that H. pylori. It really depends upon. But once if you have diagnosed and if you have the identified this H. pylori infection, so by WHO, this is the carcinogen, the and that needs to be eradicated, but the patient should be taken as a whole rather than only the H. pylori test. So I hope, my dear colleagues and PGs, that in today's lecture, we have been able to discuss the different treatment options available to us for H. pylori eradication, the practice essentials, how these different regimes may be used to get the best possible results. What are the according to duration, the 1 week or 2 weeks, and then the triple therapy and quadruple therapy, and what is the hybrid therapy, the dual and quadruple, or reverse hybrid, the quadruple and dual, and what is the sequential therapy. So I tried to explain to you with the graphs, with the bars, to give you the concepts that how, what do we mean by these therapies and how we should use these therapies in these patients. This is very important when a patient comes to you with H. pylori infection. You inquire about the previous antibiotics used, then what antibiotics have been used, what drugs have been used, for how long duration they have been used, what was the compliance, what was the combination of these, and what was the duration. Until unless you go through all that record, it becomes very difficult to offer that patient the most appropriate H. pylori eradication treatment regimen. This is very important that you give time to the patient and you go through whole the record, and then you decide upon that whether the patient needs which type of therapy, if the patient is treatment naive. So, and depending upon, you may go for 1 week, or desirably you should go for the 2 weeks therapy, then triple, the quadruple, if this is the treatment failure patients, whether this is the source of the second line therapy or the third line therapy. So this is very, very important that you tailor your treatment according to the patient needs, or the patient's case, or the patient case history, or the patient scenario. So with this, I stop the my presentation, and I hope that it has given you the concepts of the practice essentials of H. pylori treatment in the 2023. Inshallah, when further updates will be coming, I'll be sharing those with you. Till then, Khuda Hafiz, take care of yourself.